Okay, then I suppose we can start today's meeting. I'm happy to greet you all at today's webinar that is dedicated. The very important topic is the tracking the healthcare expenditures, how to allocate financial resources in health financing. It is very important to form health policy based on actual data. And due to this, myself and my colleagues, Baktygul Akkazieva, would like to share with you experiences that we have both globally and how this process was implemented in our country, in Kyrgyzstan. We, together with Baktygul, is going to present 3 presentations for you, such topics as understanding what is national health accounts, how it is applied, what methodologies and applications existing, how to keep such accounts. Baktygul will show us example in Northern Macedonia. Then, as in last presentation, I will share with you experience from Kyrgyzstan and will show some data that we got on health expenditures and how it could be tracked thanks to national health accounts, and what barriers we have in order to get those health accounts. So we are suggesting the following mode for today. We have 3 presentations. After each presentation, you can have questions for clarifications, but more broader discussion we plan at the very end of our webinar, after all presentations, when everyone would have opportunity to ask all the questions. I would like to express my thanks for joining this webinar, and I would like to give the floor to Baktygul Akkazieva. Baktygul, the floor is yours.
Thank you so much, Adyl. Yeah, great, great. Thanks a lot. I'm really happy to be part of this webinar. Yes, as Adyl mentioned, my name is Baktygul Akkazieva. I would say, like, I'm a health economist, health financing expert. Until recent time, I was at WHO staff at the European region and the Barcelona office, and I was responsible for the institutionalization and production of the health accounts in the European region. So I just recently joined the University of Geneva, and so therefore, I guess I'm part of this webinar, and I'm originally from Kyrgyzstan. So I'm like, I have a long-lasting relationship with my friends, Adyl, and the whole HPAC team. So I'm very happy to be part of this, and I would like to give you, so let me share my, so as Adyl highlighted, we will do, 1 second. Can you see my slides? Yeah, perfect. Great. The way how we are going to work today is that, so I'm giving the presentation of the first session, and then after the first session, so we will have questions for the clarifications, and then after the first session and questions and answers, we will have the second session. But I mean, feel free to answer the question, I mean, to ask the questions in the chat. Adyl is kindly checking the chart, and you can put there, and I can pick them up and respond after this first session. So During this session, we will discuss why tracking health spending is essential for policymaking globally, and I will give you a couple of examples also at the European region, WHO European region. We will explore the purpose of health accounts production and what kind of method used to estimate, to track the health spending, and why it's important, and including some advantages and disadvantages. So tracking health spending is vital for informed policymaking. It allows countries to establish robust institutional capacities to generate evidence and make an effective decision, especially in designing universal health coverage systems. 10 years ago, the World Health Assembly called for stronger institutionalization capacity to track health spending as a step towards universal health coverage. And all WHO member states signed the resolution on sustainable health financing structure and universal health coverage. And you can see that tracking health spending is an integrated part of this resolution. What do we mean by tracking health spending? Tracking health spending helps to understand how money is raised, allocated, and used. To ensure universal health coverage to be implemented or to reach, tracking health spending helps evaluate financial protection, equity, and resource distribution. So basically, where does the money go, who benefits, and who pays? And also, it helps to understand the efficiency, how effective and efficient the system, technical input mix, and allocative efficiencies. Let's examine where funding for healthcare comes from. So we can see that the funding comes, it's a mix of the government, private, and out-of-pocket spending. And you can see the green colors are government spending, which includes budget and contributions to the health insurance. And then red is out-of-pocket spending by population, households, and yellow is a voluntary health insurance. So you can see it's quite a bit of mix of the different source of funding. Okay, you can hear me, right? Once again, I really apologize for these technical inputs. Before we joined, before we started this session, we tested everything. Everything was working. So, but yeah, so we have to blame the technical aspect. Where did I stop? I stopped talking about the mix of the funding that we have at the countries and the funding sources of the health system. So it's a mix of the government spending, basically budget and contributions, and then out-of-pocket expenditure, which is done by the population, and the voluntary health insurance, which is also like a contribution, but voluntary contributions done by the population. So the next slide, so this chart shows you how much the government spends funds on health. Basically, we health economists think this indicator as a priority indicator because if we consider that the government prioritizes the health, so it allocates more funds to health. And we suggest that it should be minimum 12% out of the overall government spending. 12% should be allocated to the health. Here you see that the countries in the WHO European region, and you see that most of the countries in the EU, among EU countries, Western European countries, so they allocate more than 10% of their government spending, telling us that the government prioritizes health expenditure, health spending, prioritizes health among other sectors. And this is, we can see that on the other side, the low-income countries, including Central Asia countries, unfortunately, the house spending from the government is not much fund. Why would the government spend more funds? Because we observe, and there is a strong correlation between the out-of-pocket spending and the public spending. And we observe
Excuse me, Baktygul. There is a background sound. I don't know if it comes from you.
Or no, it's an echo or
it's like a hammer.
No, I don't have. I'm sitting in a very quiet room.
Who has a hammer?
Are you listening to me?
No, all microphones are switched off. Откуда-то от тебя идет. Все микрофоны мы выключили.
Just one question. Are you sitting at the English channel? Are you listening the presentation at the English channel?
Now I'm the original, but both. Wait.
No, that's in the original there's no sound. In Russian there's no sound, but if you switch to English there is sound.
Okay, so we should switch to the original.
Okay, so switch to the original.
It's better. Let's see how it goes. Thank you.
Please say it properly. So there is, again, I'm repeating again, so that we observe that where governments allocate more, patients pay less. And this slide shows you this correlation. And we see the countries who pays spending, public spending on health as a share of GDP, for example, like Spain or Switzerland or other countries, as you see on the right side. So they spend more than 7%, 8% of the GDP. Their out-of-pocket expenditure about 10, 20%. Why we talk about it? Why it's important? Because we observe the correlation that financial protection is stronger where the out-of-pocket is less than 15%. And this is, you see the dots, and this is, you see the results from the studies that have been done in the European region related to the financial protection. And we are confident to say that where out-of-pocket expenditure is less than 15% of total health spending, the financial protection is stronger. But of course, also the different policies at the country levels, it's also very important. Additionally, there are many evidence shows that low spending on health leads also to the worst health outcomes. There is a strong link. You can see that, for example, Slovenia, so they spent about 2,000 PPP international dollar, and their mortality rate per 100,000 is rather low than about less than 100. And then you can see the Latvia, which is spending about like 1,000 PPP per capita. And then you see that mortality rate is per capita is per 100,000 people is higher. where you see all this data, where you can get all this data, and why we are talking about this. This data can be found at the Global Health Expenditure Database. You see the link where you can find all the data, the one that I presented to you. And the examples that I gave it to you is just to showcase why and how we use this expenditure data in the policy and how it can be used for the at the country level. And how we track this spending. So basically, there is an international methodology that has been developed by the WHO, OECD, and EU countries. And it calls System of Health Accounts. So there was definitely a need for a common language and where we can standardize all the expenditures, and then also to make all the data consistent and to comprehensive, so that it can be contributed to the evidence-based policy making. Basically, health accounts consist of these 4 core classifications. It's on providers, hospitals, and different providers, preventive care providers, administration, Then we have their functions, which we call in health accounts is service delivery, basically curative care, rehabilitative care, long-term care. Then we have source of funds, from where the funding comes to cover all the expenses of the health services and expenses of the health providers. And finally, disease. Of course, there are more classifications we have in the health accounts, but here I just wanted to highlight these 4 core classifications that we have in System of Health Accounts. The complex questions here I would like to show you makes the health accounts helps to answer. For example, such questions as, do we spend enough in preventive services? Or how much is public health expenditure compared to the other countries? Or how much do we spend on primary care, on secondary care, or on prevention? And what is the private contribution to the medicine spending? Are public funds enough to cover diabetes costs? So all these questions can be answered through their health accounts data. Here I'm presenting you the tables that we're getting as part of this exercise. Each country, when they produce their health accounts, we get this is 2-dimensional, 3-dimensional, different types of the tables. For example, we would like to know how much you spend population or households out of their pocket for their outpatient curative care. So we can get from this table. Then these tables looks very complicated. So definitely from the first time when everyone sees this, they're like, no way, it's not possible to do it, or it's so complicated. But it's not so scary. So because afterwards, all these tables we can put in such a nice fact sheet that we are preparing for each country. And it depends on all the data that collects each country, and depends on how much efforts they've done in the quality of the data. So we get such kind of information as and also answering the questions, is health is a priority for the government, and what are the source of health funding, what health conditions are focused on spending. And so these are the questions we can get, and such very nice and beautiful country fact sheet can be prepared for the countries, prepared by the countries. Basically, the key takeaway message from this session, talking about the health accounts and why it's important. It's an essential to understand the spending at the country, at the regional, and at the global levels. It's a very powerful tool, and it can contribute to the monitoring of universal health coverage. And it's not only about the numbers, but it's about improving health outcomes, because we can link the expenditure data with the health outcomes, and then we can also present what are the issues at the country level. One final message here I also wanted to mention is that often when we talk about the health accounts, it's always talking that it's accounting, it's a very boring and it's very complicated. No, health accounts, as I highlighted, it's a tool, and it's a very interesting tool which can provide lots of insightful information for the policy makers. So here I would like to stop. Oops. And I would like to stop here and ask the questions for the clarification. So I know that, I mean, this first session had a little bit of issues in terms of their technical issues. I'm really sorry, but I hope that despite of this, or you got the main message from this. Yeah, so we have about 10 minutes for the questions. Yes, please. I think I see the hand from Maria.
Yes, thank you very much. Very, very interesting indeed. And I was surprised to see specific information about, for example, curative costs. And that is very particularly interesting for Peru, where we struggle a lot to have this information available that could inform or be used in economic evaluations. So how can we access to that so we can see what information is available for Peru? Well, that's one question. And my second question is, in your experience, how reliable is this information, and also what you could tell us about the quality? And from the NCD policy lab, do you think that there's something we could do to help our Ministry of Health or health system to improve the quality of information that the WHO probably gather? Because there's always a lot of comments regarding this information from the Food Choice Project, and even here at my university in Oxford, I heard from a supervisor like, I don't know if that is enough or updated or high quality for your country, for example. Thank you very much.
Mm-hmm. Okay, so I put a list. Should we get a bit more questions, or I answer this question?
Hi.
Okay. Yes, yes, please go ahead.
Just a small question. And I understand this is something that you do like periodically, or is it like once in a time, or how much, like what is the follow-up to see if there are any advancements in the health expenditure?
Okay. Any other questions? Or I will start answering, and then if you have one more question, then I can take one more question. So let me talk like maybe from the last question in terms of how often is done this data. Basically, the health expenditure or health accounts is done on a yearly basis. And this is the data is collected on a yearly basis, and we argue that each country should collect the original data and not produce something kind of a new additional information. So, but it depends on the country how the data is reliable, and I'm connecting to the previous question in terms how the data are reliable and whether the quality of the data. Again, so it depends on the country and the team who is collecting the data. And of course, there are a lot of questions about how the data is collected and what are the source of the data. So when this exercise is done at the country level, so the team should verify the data. And then there is also a team at the regional levels. For example, for Peru, for example, these are the at Pajo region. So WHO in Pajo is responsible for the production, is responsible to follow up and oversee the production of the health accounts in the Pajo region. And I'm sure in Peru, you do have this production of the health accounts. So basically each team should produce this data, should look at the quality of this data, and then afterwards submitting the health account studies to the headquarters where I showed you this global health expenditure database. At the end, the data is ended up in this global health expenditure database. So, but before the data inserted into this global health expenditure database, the team in HQ, so they are checking the quality of the data and checking whether all their data connects the dots and all their data in line with the policies. Sometimes we see some awkward figures saying that, okay, so it doesn't make sense. So basically, we try to scrutinize all the figures that are published there, but of course, there are always questions. So, and where you can find this data in Peru, I suggest that you can get in touch. You can try to find out in the Ministry of Health, who should be a focal point for the production of health accounts. And it's applicable to all the countries in Afro region, in Pajo region. If you get in touch with the Ministry of Health, you will find out whether you have a focal point on the health accounts, and then you can talk to them and see what is the status of health accounts production and how the data collected and granularity of the data. In my next session, I will show you the global usage of the data, and I will show you also how many countries collecting this data and what are the issues we have in the collection of the data. So in the next presentation, I'll give you a bit more information about the data collection process. Yeah, I think I answered the question. I see the thumb up. Any other? I know that it's a very, how to say, not complicated, but a new area for you. So let me start with my second part of the presentation. So I'll try to be short as well there, and then to open a bit more floor probably for the questions. Let's do like this. If you are unclear with some of the slides, please, you can interrupt me, and then you can ask me the questions, because I think we are running out of the time, right? I said how much time we have. I probably eaten up all of the time.
We have 1 hour and more, but if it is needed, we can stay longer. I mean, take more time.
Yeah. Okay. I hope that this time we won't have. I won't have any technical problems. So let me start with my second part of the presentation. I hope that I won't make any troubles. Okay, let me share. You see my slide?
Yes.
Good. Okay.
Super.
So my second part of the presentation, during the first part of the presentation, I made the introduction of what is the tracking expenditure and how we do the tracking expenditure using the health accounts tool, system of health accounts tool, and why it is important and how it is related to this global initiatives like universal health coverage. Here I will show you a couple of examples how these health accounts are used and also how it is produced. Basically on this slide, you can see that 194 countries in the worldwide producing the health accounts. But we, but we see that basically there are a lot of problems with collecting the data on a disease. Because the second column, you see that 192 countries, they are submitting data on a expenditure related to the source of funds, from where the funding comes. Then we have 134 countries worldwide submitting the data about the services, how much funds spent on the different services, basically functions of the health systems. However, we have only 63 countries submitting and collecting the data. Yes.
I'm sorry. I think you're not sharing your screen.
It's not shared?
No.
Okay, 1 second. You see it now?
No. No.
I see it.
You do?
Me too.
Yeah.
I see the screen.
Yes. Data availability at the global level, it says.
Yeah, data availability at the global level.
So where is it?
Mm-hmm. So I'll keep and you try to find it. If you don't
Yes, I found it.
You found it?
Sorry.
Okay. Sometimes the issue also, if you have a few screens, so then probably you may lose it between the few screens. So what I was saying is that we have a good data on the source of the funding, on the services, but unfortunately on the disease expenditure, we have a limited data. Only 63 countries submitting the data on disease, which makes further to make a deeper analysis by disease. And I'll show you later which kind of analysis we can do for the disease, and especially for the non-communicable disease, focusing on the diabetes, that we were lucky enough to collect this data at the Macedonian, at one country, not only one country, but I will give you an example of one country in the Western Balkan countries. So how the data on health accounts are used globally. I showed you there's 193 countries so submitting the data overall on health accounts. And so first of all, of course, at the global level, this data used for the comparison purpose. You see on the right side, so that we have the global health expenditure database. If you go to this global health expenditure database, you can explore this and you will find the different indicators and all the data that were submitted, expenditure data was submitted by the countries, you can find in this database, in this platform, and by the different indicators and also functions. And afterwards, at the global level, basically headquartered at the HQ, so they analyze all the figures, and then they put this in the global spending report, which is published on a yearly basis for the last 5-7 years. And the last one was published last year in December, and this year is going to be published a new report on a global health spending. Each year they are providing new information, and so they use also different topics for presenting their analysis. And of course, development partners at the country level, so they use extensively this data on the expenditure, global health expenditure data. I know that Global Fund, Swiss government, World Bank, all the partners, so they're looking at this data, and especially they are very much interested into the data which is related to the services, and to see how much funds to spend on the primary care. Of course, they are very much interested also to look at the disease expenditure. In the next few slides, I'm going to show you a couple of results from the latest global spending data, global spending report. But if you're more interested, you can always go and find this data, this report on a website that they provided. So we see that health spending globally after the after COVID has been increasing, but however, after in 2021, we see there is a stagnation, or there is a decrease in some countries. The spending on health has been decreased, but before, of course, from 2000 until 2021, we see a huge increase of the spending on health as a percent of the GDP, and as a percent of GDP. We see that the government, so they are prioritizing the health, and so they are putting more funds or allocating more funds to the health. And especially this is like in 2021, except the low-income countries. Unfortunately, yes, in low-income countries, we don't see such a huge increase as in other countries. And out-of-pocket spending on health has been increasing lately. And before COVID, it has been increasing always. But then during the COVID time, it was stagnated or even decreased. But after COVID in 2021, so the financial burden on population again has reversed, and people start paying out of the pocket again as pre-pandemic, as before the pandemic. So primary healthcare spending. It's a very hot topic around the global, and everybody is interested how much money is spent on the primary care, either by the government or out-of-pocket expenditure. But in overall, we see also what is consist of, what is like the main driver of the primary healthcare spending. And on this slide, we see that the main driver of the primary healthcare spending is medicines. You see the green, the green part, and then the second one is ambulatory care, and then we see also the preventive care providers. important to highlight that depending on the definition that each country put under the primary health care, so the level of the primary health care spending depends on the definition. So as part of this global report, it has been highlighted that each country needs to define the primary health care as the at the country level, not using the global definition, which has been developed by the WHO only for the comparison purpose. So, and developing the definition at the country level helps to track more accurate spending on the primary health care. On this slide, I show you the spending by the different providers, and we see that by the different providers and using the global definition of the primary health care. Then in this slide, we can see also it's another way of presenting the data. It's also presenting the data by their providers, and we see that the total spending on health in during the last between 2019 and 2021 is almost the same. So there is no much differences, but this is another type of the provision of the data by the providers. Before the previous slide I showed you, it's presenting the figures by functions, by the services, and here by the providers. Again, this is another type of the analysis that has been done using the functions and using the functions. And here we see that basically outpatient and prevention and preventive care are delivered across multiple healthcare providers. You can see that it's provided by their ambulatory care providers and by the preventive care providers. These are very preliminary figures, I would say, or rough figures from only 18 countries that my colleagues and headquarters were able to analyze by the disease. And we see that between 19 and 2020, the expenditure by the different disease, the way how it is presented here, as you can see, it's a non-communicable disease. We have a green, then we have reproductive health, then we have HIV and TB, then injuries and unspecified disease. So in this graph, you see that basically in low and middle income countries, they spend about 14% in between 12 and 14% for the non-communicable disease. But what is included non-communicable disease? It needs to be like more detailed analyzed. And here, I think it's we cannot give a robust evidence based on the 18 countries, right? We need to do more analysis on this, and I will show you further the analysis we have done for the North Macedonia. So if you want to see and to read more about this analysis that had been done based on the global data that were collected, please go to the Global Health Expenditure Database, and you can find the different reports, and you can check and you can see what kind of the data is there and more in-depth analysis. So this was the data or the usage of the health accounts data at the global level. So the next couple of slides, I'm going to present you what has been done in the European region. This, like European region, one of the leading region where provided majority of the data globally. And basically, it's because in OECD and EU countries, producing of the health accounts is a routine statistical procedure. Basically, all the EU countries or OECD countries, so they are obliged to produce the health accounts and report to the Eurostat. So it's done on a regular basis, once a year. So they are submitting this data to Eurostat and also submitting the data to WHO and OECD. Basically, this is like to 3 organizations, and of course, or WHO is different levels at headquarters and the regional level. Then in the European region, we have also other countries which are not EU, and these are Western Balkan countries and Eastern Europe and Central Asia countries, where Kyrgyzstan is part of this. So these countries are not producing this data on regular basis, unfortunately, though WHO had been working very hard to make the countries report this on a regular basis. But due to the political situations in the country, so not all the countries keep producing this. And again, it depends on many different factors. In short, to say that all the countries, once they submit the data to headquarters, so then we have the validation process. I mentioned already to you, so that there is a team in HQ who are doing this validation together with the WHO regional office, checking all the data and see whether all the figures properly coded and clear, and try to understand whether the quality of the data is good or not. And afterwards, this data are published in the Global Health Expenditure Database. How are the health accounts used in the OECD countries? So the reason why I have chosen OECD countries is just because, I mean, you've seen that it's very robust and production of the health accounts in these countries, in OECD countries. And so basically, they use it for the international comparison, so between the countries. Then, in order to do more in-depth analysis on the health services, so basically also financial sustainability, in order to evaluate the reforms and also to monitor towards the universal health coverage where they are. And also, of course, efficiency analysis, which is like very important. So in OECD, SHA methodology is a reference guide and a very flexible tool. So it depends on the priority and the policy. Basically, each country, so depending on the priority and policy, so they do the analysis and they prioritize which area they need to do in-depth analysis, like either the primary care or rehabilitation area or rehabilitation part of the system. So basically, each country makes their own decision on this. A few examples from the OECD countries. It's United Kingdom, UK. So they introduced the health accounts like about 10 years ago, and statistical offices are responsible for the producing this. And it's a very important piece of work as part of the health sector. Basically, all the data are discussed at the steering committee. So this is important for the government to produce this on an annual basis, and the quality of the data, of course, are good. In France, this is part of the routine production of the health accounts. It's a part of the routine procedure, and they're taking it very serious. So they are producing each year the reports on health accounts with extensive analysis, and then they're discussing this at the different commissions, and then once a year they are presenting all the data to the Ministry of Health, and so they're selecting different areas which are important to discuss. Then Germany and European Commission. I'm not going to go into the depth, just to say that, I mean, these are the data are important for their developing different policies in Germany, and they're using it like to on a daily basis, I would say. And of course, European Commission always use this data to review and check the data, and especially lately on the long-term care. I think this is like an important information that they're collecting from the health account studies. North Macedonia, the one that I have told you at the very beginning. North Macedonia is a very successful story in the European region, not non-OECD, WHO European region. It's been for I would say 7 years ago, we started this journey of production and institutionalization of health accounts in North Macedonia. And as of today, it's a pioneer in this region of the production of the health accounts, and it's been producing on a regular basis. And statistical office now is responsible for the production of the health accounts, and there is a team in the health insurance fund for collecting the data and producing the health account studies. The challenge is that policymakers are not using this data yet much, and so therefore last year in December we did a big workshop there where we presented the figures from the health accounts on spending on health, spending overall trend on the health spending in North Macedonia, primary health care, mental health financing, and the diabetes spending. So these are the figures were presented at this workshop. The fact sheet has been produced as part of the health accounts work in North Macedonia, and you see that these are the key and core information you can get on a health spending, basically. How much spend on health as part of the GDP. Then we see their financial protection, what is the out-of-pocket spending. Then we see from what are the source of funding and how much government spend. And then the primary healthcare spending, how much government and out-of-pocket spending on the primary healthcare, based on the local definition that has been developed by defined by the local team. Here, just a couple of results. I'm not going to spend time, but just wanted to show you that 2021, the North Macedonia spent about half of the expenditure is on curative care, preventive care only 4.3%. And rehabilitative care only like 1.1%. So this is the picture on how much spent on the different types of the care. When we talk about the curative care, what do we mean by the curative care? So it includes outpatient curative care, which is like 45%, then inpatient curative care. So basically they are almost the same. So spend as a share of the curative care. Looking at the type of the care, what kind of care we have in North Macedonia and how much money spent. Basically, we see that, of course, the leading or the driving type of the driving spending is basically curative care, and then medical goods. So these are the two types of the care where we have the majority of funds that go. Diagnostic, it's the third type of the care. Health spending by providers. We see that in North Macedonia, 38% of their spending is allocated to hospitals. And to their ambulatory care, it's only is less, 25%, despite all the reforms that the government tries to put on and focus on ambulatory care or primary care. So it's still the hospitals leading with the spending. These are the disease. So we see that on non-communicable disease, about 36% that spend are allocated for the non-communicable disease. And 41% is unspecified disease. So we try to understand what is it. I mean, what kind of diseases are included here. But unfortunately, when we did the analysis, we tried to dig into the data, but we couldn't understand what kind, I mean, we couldn't refer to which of the disease we can put this expenditure. So this is, this shows how the poor the data, the quality of the data, and then also potentially reporting on the data. What do we mean under the non-communicable disease? I would like to unpack with this slide and show you that basically it's 21% is a cardiovascular disease, then 12% it's our like diabetes spending, then cancer it's about 10%. Mental health is about like 10% as well, 10-12%. Basically, such kind of analysis we were able to do it and to unpack non-communicable disease in Macedonia. But notably, this 41% that we couldn't specify could be part of this also non-communicable disease, but we cannot do it because of the poor quality of the data. Over the last 5 years, the expenditure on diabetes has increased by 0.1% of GDP in North Macedonia. It looks like a very tiny percentage, but in reality, it's quite big. What are the leading or driving expenditure is a pharmaceutical, basically is a medicines. Potentially this is insulin spending on insulin and other medicines. Then we have an ambulatory general, about 20% spending. We try to understand how much spent on a primary health care, which is our country-tailored definition. So, and we see the same picture. We see that about 81% out of all primary health care spending goes the medicine. So laboratory services is very low, and we don't know why dental included here. Basically, these figures showing that potentially we can get some good data, but we need to understand, and we need to clean the data. Basically, the poor quality of the data has such kind of information. But to be honest, other countries, they don't have even such information. They don't produce such information. Who pays for the diabetes services? Basically, it's public. It's a budget, government spends. When I talk public, it means government spending. It comes from the budget. However, we see that in the inpatient rehabilitative care, we have still a bit paid by the out-of-pocket expenditure, private spending, and then medicines, it's about 0.2% of population, so they pay out of the pocket. And a couple of thoughts when we did this analysis. So we realized that, and it's a fact that the data from the health accounts can tell us the current situation, can tell us the trends of the spending. And then also it can help us to identify the areas where it has to be, we need to do some changes. Then it can help us to identify what are the role of the primary care, because primary care is one of the important part, and also it's a key for the diabetes, because like if we have a strong primary care, so then we can have a better management of the diabetes. So this is like one area we have chosen, and we have thought that it's important to highlight. And basically, data is needed to improve the quality and ensure the towards the universal health coverage. So key takeaway messages. So countries should use the health accounts and potentially maybe some other tools, but we are advocating for the health accounts in order to produce, in order to develop evidence-based policymaking, especially in their health financing area. Invest in a good quality data to track spending and overall spending. And finally, we say that, and we see that under-resourced health sector creates a vicious circle of poor quality. Basically, trust to the health can be poor, and then access barriers is poor, and then increasing the financial hardship, leading to the low trust to the health services. So we need to invest into the health system. So with this, I would like to stop my presentation for the second half, for the second session, and I would like to open the floor for the questions.
Oh, I hope you can see my presentation. I will switch off my camera in order to have better quality of my voice. Dear colleagues, first of all, I would like to thank Baktygul for her presentation. And let me tell you about Kyrgyzstan's experience to develop an introduction of national health accounts, how this process was implemented, what barriers we faced, what lessons learned we have in this process. So, okay, what are reasons and what was the background to have any national health accounts in Kyrgyzstan? So, by launching of these accounts, we had already some long period of reforms in healthcare, including financing of health. And those reforms were within programs named Manas and Manas Talimi. And country was conducting them 2000 up to 2010. And during those reforms, such activities were done, like centralization of public health resources, and reporting data in mandatory health insurance fund, single payer system. We implemented mandatory health insurance system because before that everything was paid from the public government budget. Now the employed population contributed to the health system. In addition, we changed the methods of funding health facilities, including per capita financing. Also, we introduced treated cases payment at the hospital level. Also, we agreed with the Ministry of Finance that health would be financed as a single budget line, and then later health facilities would distribute their funds according own demands. Also, co-payment was introduced. That was part of introduction of mandatory health insurance fund. Now, insured population can pay co-payment. It means partially reimburse, partially will be reimbursed. So for insured, co-payment was lower than for non-insured citizens. At the same time, the country has started at that time forming a program-based budgeting. It should be also noted after 2010, health financing was changed, wasn't so fast. It was slowed down, and some actions were only some targeted, had some targeted approach. So we tried also some performance-based financing. So when we took into account not only the number of cases, like treated cases or insured population, but we tried to take into account also performance and quality of provided care. Also, we also tried to introduce incentives payment for medical workers. So based on those scores got by the providers, and it would also would be like top up to their salaries, top up payment. Kyrgyzstan on implementation of health accounts among countries of Eastern Europe and Central Asia was a pioneer, and we started, we were first who started, but recent years we cannot tell about this. We don't have such big movements related the health accounts. And in fact, the history of implementing of health accounts in Kyrgyzstan has some stages. The first attempt to introduce it was done in 2001, when we started formation of this. There was a research team was established, supported by USAID. So we made primary data collection, and we tried to form first matrices and to use methodologies and approaches to discuss them globally. But this work was just one-time work, and it wasn't continued. Since 2005, the National Health Accounts development and implementation was supported by WHO, and up to 2010 methodology was developed, and how data was analyzed and collected, and we also developed guidelines how to do it. And during that period, we identified the work that we made annual reports for 2004. That was a pilot year when the country tried first time to do such a report. And later, 2006 up to 2009, we used to publish annually such health accounts reports. Also, in 2007, we also developed TB sub-accounts. Also, we also developed a work when we made some calculations by diseases, in this case TB. Also, during that period, Kyrgyzstan has actively participated at regional level. If we look globally, in various parts of the world, there were different regional networks were established. And in former Soviet countries, there was an Eurasian network was established that was functioning during some time. And in Kyrgyzstan, we conducted 3 regional health workshops, 2006, 2008, and 2012. And in 2012, it was the last regional workshop, and we decided to move to health methodology 2011 that Baktygul mentioned, and we applied that methodology for our annual reports. Because that were a bit different methodology, and we understood that this methodology should be applied, and globally there was a switch to this methodology. And during that work and other works later, as I told, that there were some issues. In 2018, there was a decision made that National Statistics Committee would be responsible, not the Mandatory Health Insurance Fund, because National Statistics Committee has experience working on various accounts, including national accounts. And it was agreed that health accounts would be sub-accounts, and sub-accounts in National Statistics Committee. And it was, in fact, also reflected in national program. It was a national program for 2019-2030. Okay, what data sources we use in order to develop our national health accounts? We use the standard reports that are produced by Ministry of Health, MHIF, and government. And non-governmental expenditures, we used data on the surveys of households with the support of WHO. National Statistics Committee separately included a module on healthcare that allowed to get detailed data on the expenditures from population on healthcare. But later, the WHO had no opportunity to support this work, and this module was adapted and integrated in the National Statistics Committee work. And we don't have such a detailed information, but it allows still to evaluate expenditures of population for healthcare. And also the third source of data on financing, on health financing, we get from information provided on budget support or intersectoral support by our private, development partners, as a budget support or like other donors who support the healthcare as a external support for development. Unfortunately, as for the data on non-profit organization, NGOs, and private healthcare providers, unfortunately, we have no data. And we don't have also either methodology how to collect such data. It is also looked as a huge, but as Baktygul demonstrated you already, such a matrix, how we can track all the health financing flows, but it allows us to get some important indicators, and we can form a picture how financing happens in the healthcare. Also, we can look how much health is a priority within our economy in this country. For example, if we look at Kyrgyzstan, we can say that the expenditures for health as for share of GDP, it's 4.5% only. And we can say that also we can say from where financing comes to healthcare. And based on the 2019, we can see that government financed 54% of the total, and 46 paid by population. And we can see how the public expenditures are formed. So we can see, of course, we can see that it is taxes, and also we can see also insurance contributions that come to healthcare. Also, we can see priorities for healthcare in the budget, and we can see the share of public expenditures. It is 7% only, and also we can see how it is allocated, how much for hospitals, how much for outpatient, how much for drugs. And Baktygul has already showed you on the from Macedonia example, and this is Kyrgyzstan, for example. We can see the same indicators. Also, I would like to stop on those results that we have in Kyrgyzstan that were made based on the health accounts. And first of all, I would like to show, first of all, when we speak about health expenditures, we are talking about share of GDP. And we see, if we look the dynamics, the health spendings were more or less more than 7%, but in dynamics we see that the share of health expenditures were reducing. If initially in 2014 majority of total expenditures for the household payment, so it was less than 3%, but by 2021 we can see the difference in share. So in GDP that expenditures of population actually is different. It shows the policy of the government, how much it was reflected in expenditures, that policy on providing the financial protection, how it could be reflected on this ratio change. If you remember, I was already mentioned on use of various sources to get data in order to evaluate data on external spendings. And we can see here that after, when the National Statistics Committee stopped using WHO methodology, so we can see getting less detailed data, we see that some data is missing and the picture is not full. As we look at the dynamics since 2000 up to 2020, as for the public spendings per capita, for 10 years it wasn't changed. They didn't change. Spendings were not changing. So it means all reforms conducted in the health sector, they were just kept at the same level. It says that at certain moment that priority, the healthcare as a priority were not kept in public spendings. Other sectors got more attention of the government. In addition, it should be noted that a quarter of population are not covered by health insurance, and accordingly it also limits of course getting resources, enough resources in healthcare, in health sector. And if we make some international comparison, Kyrgyzstan has a smaller than average size of government budget as a share of GDP. Then we can see that we are in a very low level. Even post-Soviet countries, if we look at post-Soviet countries that are within the EU, we see that in fact we have very low expenditures and spendings on healthcare that also limit opportunities for health care. But at the same time, we can say that if public spendings are not high, as for the out-of-pocket payments, as a total share of health spendings is higher than in region average, but also in European region. but it is almost the same level as other CIS countries. Here, I would like to show you the same indicator that Baktygul has showed in her presentation on Macedonia. So health spendings by disease in Kyrgyzstan, how the financing is provided by various diseases. And you can see the diabetes expenses that is most interesting for us within our work, current work. It's only 1% out of all expenditures for healthcare. But at the same time, if Baktygul showed in Northern Macedonia, 41% expenditures were not, they couldn't allocate by disease. In our country, it's 47% of total expenditures. There was not opportunity to identify for what diseases exactly the funding was, the spending were made. As for diabetes spending, if we look at dynamics, we can say it almost hasn't changed since 2014. It was less than 1%. But at the same time, if we look at spending by funding sources, spending on diabetes, we can see that majority of spendings are made at expenses of Republican budget. Some part is made, it's MHIF, mandatory health insurance. And if we look at the population expenditures is not high, it actually reflects the policy that is conducted in this country on diabetes. It is free of charge insulin provision, some privileges in providing diabetes care that are made at expense of the government. And as for spendings on what exactly the spendings made on, so majority is made on inpatient. We see that here since 2018 more it's 51%. So here we need to say that why it is a big difference. Before 2018 inpatient was 70%, when the drugs were not so high share. It was just 2-3%. But then since 2018, the share for the drugs spendings increased. It was up to 25-30%. It is all made due some technical moments. It is important, and Baktygul also has mentioned about it. It is important to look at methodology, at approaches, information of the health accounts, and we found out that such difference happened due to fact that expenditures for insulin were not included in the spendings on diabetes, because all expenditures on insulin is made by Ministry of Health at centralized level. They procure insulin for the whole country, and then they distribute among health facilities and then among patients. And it turned out that before 2018 they didn't take this fact into account, this fact, especially So insulin was just in other expenditures, and they were not classified as, insulin was not classified as diabetes spendings. But then, after the application of the correct methodologies that insulin should be shown separately as a diabetes spending, and then we see the changes of the tendency of the share of financing on at various levels of care. And speaking about results, I would like to just mention the main issues that we are facing in this country on implementation of the national health accounts. First of all, I would like to mention that that institutionalization process has not been completed. As I mentioned, that currently National Statistical Committee is working on the collection of these health accounts, but they are not doing it fully. They didn't approve the methodology, and that's why this work has been stopped. At the same time, the Ministry of Health and other government agencies have very low, poor understanding of this importance. That is why so lack of information provided by health providers, it doesn't allow to see the full picture. As for the external financing, of course, we do have some information from various sources, but there is no opportunity to track fully what funds are allocated by our development partners to health sector. Also, we have, of course, problems with data provided by providers by function, because they cannot always provide data on what functions exactly they allocated funds. They not always can identify financing of what functions they did. And also, as I already mentioned earlier, that there is a lack of information by disease. So it means we cannot actually identify financing by disease. And about next steps, first of all, of course, we need to complete the institutionalization of health accounts. Of course, we need to build capacity of the national team. We need to strengthen efforts to use health accounts. And we need to continue improvement of data quality and reliability. Of course, we need to identify how we can get more detailed information on external funding, also financing by disease. I wanted to mention why it is important. In fact, all countries, by certain, they all track their health expenditures. Some of them do it more complete, some of them partially or fragmented. But anyway, all countries track. But introduction of such national health accounts actually allows to have more detailed information and to compare own data with other countries. It gives an opportunity to assess own indicators on financing, own policy, own situation, on finance, health financing with other countries. It gives an opportunity to exchange experience with other countries in order to solve some issues related both to financing and functioning of the health system in general. That is all that I wanted to tell you about of Kyrgyzstan. If you have any questions, I have, if not, but we have some issues for discussions here. I put I think these issues we can discuss all together. Thank you.
Да, Мария.
Yes, thank you very much. Really very interesting. I also love the graphs summarizing most of the relevant information. From our experience in Peru, we have found that infographics and presenting the information in a very friendly way is always has more chances to have an impact with policymakers, stakeholders. But I would also like to know, in your experience, what, how can we use this information to influence in policymakers? Like, I am imagining using this in a policy brief and or trying to replicate some of the nice graphs you showed us, but more than that, what would you suggest to do with that information? Thinking in Peru, for example, that's one first question. The second is, I don't remember that you have mentioned to relate or this information with specific outputs, because in order to use this as evidence base for improving something, I think we would need to tell a little bit more of the story, like, okay, the national health accounts in these programs, of course, is this and that, but in order to request how to reallocate or to attend more specific disease or specific program, I think we should demonstrate first that the way they are investing the budget is not getting the results that we need, right? Thank you very much.
Thank you very much for questions. As for how we can provide information, so in fact, those classifications which are applied within the health accounts, they can be interpreted differently. We have demonstrated only some very obvious indicators, but there is also opportunity to look in depth. For example, the same diabetes expenditures. We can see how much, for example, used for medical staff, for example, those who provide care, how much allocated for salary, how much allocated for utilities expenditures. So we can see how efficiently the funds used. For example, one of the indicators that was a big argument to reform the healthcare in Kyrgyzstan was the utilities expenditures, because in Kyrgyzstan during Soviet times and immediately after collapse of the Soviet Union, so utilities expenditures for electricity, for heating, for water supply, they were almost quarter of all expenditures, a quarter of all health public expenditures. And it was a huge burden that actually limited to use the health expenditures. And at that time there was a decision made to restructure. When restructure the health system, some health facilities, some too big spaces were closed, or not some buildings not needed, and that all allowed to reduce expenditures for utilities, like 25% managed to be reduced up to 12% of expenditures. I think using this kind of health accounts can be used, this kind of data can show the efficient use of funding. Also, as for the policy formation, it is rather complicated issue. As I mentioned, so that regional network that was established some years ago, it was one of the relevant issues, like how decision makers could be convicted or persuaded that decisions on health funding should be important. For example, in our country, we had a problem that very often decision makers, they require more fast and prompt analysis, but health account is rather time consuming and workload process, and very often such data require such some financing data is required, for example, immediately, but some data should be time consuming for collection. And in this case, of course, it is important to form the culture how this data should be used. It's not some kind of prompt data, but national health accounts, they are more complex data and should be applied in analysis. I hope I answered to your question. Maybe my colleagues can add something if you...
There are more questions, I think, from Nina and Marina. The first was Nina and then Marina. Maybe, yes, you can go ahead and ask the questions.
Thank you very much. I have a question on the out-of-pocket information. Do you know how is the out-of-pocket survey shared, and how responsive are the patients?
Okay, maybe then, Marina, you can ask the questions, so we collect a few questions and then we will answer.
Okay, great. Well, thank you, first of all, very much, Adyl and Baktygul, for your great presentations. I just had one question, or maybe more of a clarification that can actually be addressed to both of you, and is a little bit linked to what just Maki asked. Baktygul, you mentioned in the December workshop that you had in North Macedonia, and for Adyl, I know you had a successful meeting 2 weeks ago in Bishkek on presenting data as well to policymakers. I was wondering if there were any concrete outcomes that came out of these meetings. Like after presenting the data, is there any evaluation of policy changes and implementation that is planned? And also, well, maybe you already answered a little bit to this, but is there anything to be learned from these two experiences on how to most efficiently disseminate this information to policymakers? Thank you.
So maybe I can start, Adyl, and then you follow up. Is it okay? Yeah. Well, in terms of the out-of-pocket expenditure, yes, thanks for the two questions. They are very important, and I know that I was expecting some questions related to out-of-pocket because it's a very interesting topic, and it's a hot topic everywhere and all the time. Basically, out-of-pocket expenditure, usually the way how it is estimated in the health accounts is a triangulation of the methods. So we are not taking the data only from their household budget surveys, because I mean, one of the key source of the data for the out-of-pocket expenditure is a household budget surveys, but we are not using it as a single source. So we're using also other data like administrative data where the providers collect the data on their official co-payments and official out-of-pocket expenditure. Then unofficial or other out-of-pocket expenditure, so we get from the household budget survey, and then from the national accounts, which the statistical office also collect the data. By the way, the household budget surveys are also collected by the national accounts by the statistical offices. So it's of course it's often by the policymakers undermine this data. So they always ask the question, they always say that, no, we don't agree with this data, or we are not sure that statisticians collecting the correct data. So, but we try to work with the statistical office and, of course, try to improve the methods of the data, not us only, but also working with other international partners like the World Bank. So they are always working with the statistical office to improve the collection data on out-of-pocket expenditure as part of their household budget surveys. So another source of the data that we are collecting, we are also considering always in low-income countries is special surveys or additional surveys that is collected as part of their, I don't know, UNICEF, UNFPA, LSMS. That's also some part of their it's also a good source of the data. So depending on what the data are available, so then we list and then we look and try to work. And of course, in such countries as OECD or EU countries where you have administrative data, or like in Macedonia, so we switched to the administrative data because they had a very good data from the statistical offices, and then also from the health insurance where the official out-of-pocket expenditure are recorded. So I don't know if I replied to your questions, but so hopefully soon we are going to publish a paper on this out-of-pocket expenditure. So we are working with the colleagues on this. So if you will be interested, so then we will share it with you, because it will be like it will take a bit of time. Marina, the question regarding you, were there any like immediate reflections from at least from the North Macedonia? I would probably say that it's already a year since we presented all the data. Of course, we cannot immediately see any impact or immediate follow-up, but at least, you know, we put the seed in like in the policymakers' heads. So, and they always like referring back to this data, and soon, in fact, in September this year, we had a workshop also in, I mean, for the Western Balkan workshop, where the data on house spending were presented. And again, so we're saying that these are data available, and so please consider do more analysis and do a follow-up. We developed this country fact sheet where we provided more details and providing more figures and asking and telling the policymakers, so that having this data in hand so could be could help you to request more funding. But again, more funding does not mean good. So we need to also present the case that efficient use of the funds is also, how to say, is in place. So therefore, I think it will take a bit of time in order to see any impact or immediate steps. But I recommend to all the countries who are attending this webinar, so to get the data, to put it together. But important probably that important key message is that once you have this data, so this data needs to be translated for the policymakers. The way how it has to be structured and the language that we are using for the policymakers when we are explaining what is out-of-pocket expenditure, or what do we mean by the public spending, or what does it mean the priority indicator. That has to be translated into the policy decision makers language, and then to produce the policy briefs and give it to the policymakers. And you need to have preferably face-to-face meetings and interviews, and not interviews, sorry, meetings and discussions, so that trying to provide the evidence and lobby, advocate for better spending, and on which priorities. But it will take time. Based on the evidence from the previous years, it may take 5 to 10 years to see any real impact, as we see in Kyrgyzstan, that it was like in 2000, right? Well, all those reforms done, and then we generated the evidence through these house accounts, and then over the 10 years, we see there a lot of differences, like a lot of changes have been done. Yeah, I don't know, maybe Adyl can add what I mentioned, and then about the Kyrgyz workshop that we had 2 weeks ago.
Thank you. In fact, the event that we conducted, we cannot tell now that certain outcomes already happened based on the discussions. But as for the financing and tracking of expenditures, it was a part of some part of the event. I think it was, more important that we managed to get an agreement that work on systematic use of data in policy making. It's very relevant for our country, and we agree that it should be more transparent, systematic, more predictable. So we came to common agreement that on the base of health development centers that Ministry of Health has, that this process would be started. And this center in future will help the Ministry of Health to form the needs and to form the policy. And among the data providers and information providers to explain them how it should be done. And I think it also will include the data which is within the health spending accounts. Because working with such data, the Ministry of Health itself and all stakeholders can see the volume of data and what data can be got and what information can be extracted from the data. And I think that the relevance of the tracking the data and also the understanding of all these things would be increased and would be introduced in our country.